Good evening everyone. مساء الخير لحضراتكم جميعا. I'm really glad to be with you today in this live presentation by the Instagram. Belong to the team of PTideas, and I'm really thankful for them for their invitation to have the lecture today about my track, my specialty in the pediatric physical therapy. So in a brief way, let's try to set up the protocol for this talk online. I'm going to present the topic, which is related to the assessment of the children with neuromotor impairment. That probably will be around 45 minutes, and the last 10 to 15 minutes will be for your questions. So please keep your comments or the questions to the end, because I will not be able to follow with you what you are writing during my presentation. Briefly, I'm Dr. إيهاب والي. I'm assistant professor in the physical therapy, King Abdal'Aziz University, and lecturer in the physical therapy school in the Cairo University. My specialty is the pediatric physical therapy. I had my PhD at 2009 from Cairo University, and then I had another subspecialty in the gait analysis from Salford University in UK at 2016. So today we are talking about one of the main questions that everyone working in the field of pediatric disability, not only a physio, but for all the disciplines, about the assessment protocol, assessment strategy for the child with a neuromotor impairment. What can we do? How can we highlight about the main item that we need to figure out during our assessment? So let's go directly to the presentation, and hopefully by the end of the topic we will be able to cover many of the objectives of the talk. So, we have certain questions that we need to answer when we are thinking about the assessment for the child with neuromotor impairment. First one is the why we are going to do the assessment. Are you planning to do the assessment to examine the child potentials? Are you going to identify certain problems or needs for the child or his family? Are you planning to set up a treatment goals? That's why you are looking for the assessment. You are looking for the child prognosis, or you need to confirm diagnosis, or you are looking for measurement of certain progress, and maybe you are looking for some of the research activities. So we have many questions by this way, and the first step that you need to identify exactly why you are looking for this kind of assessment. Another question can jump in the track, which is what are the tracks need to be assessed? What are the main domains that you are looking for? Are you looking for the anatomical analysis? So by this way you are considering the applied anatomy, you are looking for the joints, for the muscles, for the ligaments and all of that. Or you have another track you need to examine, which is the biomechanical one. Another therapist may concern with the functional analysis or some of the quantitative, further qualitative abilities of the child, or maybe you are looking for a comprehensive overview for the child. Another question, which is who is your target? What about your target population? Definitely we are talking about the children, but as you know, if we are talking about a newborn baby, this is totally different than you are examining an infant, child, teenager, adolescent, and so on. So the age is one of the points to be considered. Are you confirmed from the diagnosis? Because sometimes we have some of the changes of the signs and symptoms which could be related to certain health conditions or diseases over age, as well as the same scenario regarding the disability. Another point to be considered when you are thinking about the assessment of your child, which is related to what are the limitations that you can face during your testing or examination. This is considering the time, this is considering the cost, this is considering the skills and experience that to be implemented in your background, space occupying and equipment that you have, and finally what about the measurement tools in relation to the reliability and validity of the assessment and measurement procedure. How can you conduct the test? What are the prerequisites? What are the guidelines? And how often or when you can repeat your measurement in a certain intervals to check the monitoring or the prognosis or the outcome measures for certain maneuver or therapeutic interventions. So as you see, we have many of the questions that we need to answer, and any of the therapists or the medical workers in this field may think about one or two or even more of these questions when he tried to implement and design his treatment or assessment strategy. So let's have one of the case study to try to figure out this point. Let's say we have Ahmed, 20 months, and a child diagnosed with a unilateral spastic cerebral palsy. So in a brief about the story of this child, that he enjoying playing with other children. The left side of his body is less mobile than the right, with increase in the tone on the left wrist and finger. He can stand and walk alone with more weight bearing on the left side than the right one, and usually the left heel not touching the floor. So it's very clear that he has a sort of asymmetry. In addition, Ahmed has a difficult to pick the beads to play with or use a bimanual skills in the majority of the playing activities, and he can respond to his name, wave bye-bye, and has a 10-word vocabulary. In addition that he can move quickly from toy to toy, and the mother concerned about his left hand, and he laughed during walking. So from this scenario, if you have a case study like that, what is your rationale when you are thinking about the issue of the assessment procedure? Can we identify which key area that you are looking to assess, and then what are the assessment tools or the equipment that you are going to apply? Actually, if we are a physios here listening to this case study, we will say that definitely we are looking about the mobility, and we are concerning with the walking because the child can walk with some of the gait deviations. By this way, so definitely I'm looking for measurement of the range of motion. Maybe I'm going to conduct a modified tardio scale to check the tonal issues. Because he is too young, so we can conduct a two-dimension gait analysis, balancing assessment, and maybe we can go for the gross motor function measure. So based on exactly what we are looking for, what about the key area that we are looking to assess and to examine, we can now select the proper assessment tools that we can use. However, on the other side, if you are an occupational therapist and you have the same case scenario, by this way, definitely you are keep looking now for the fine motor skills, hand function, and definite ADL activities. And by this way, your rationale for the assessment and for the tools that you are going to conduct definitely will be totally different than the physio. You have some of the similarities sometimes related to the range of motion and the tonal issues, but you need, let's say here, some sort of scaling system or assessment tools like the Peabody developmental motor scale, which concern with the fine motor grasping, reaching, and so on. So as you can see, even if we have the same child, but we have different disciplines, so we are keep looking for specific items, specific concern and interest, and by this way, the assessment tools will totally differ. So, what about the limitations in these issues? If we have an assessment procedure or assessment question for the child, like Ahmed, which mentioned before. What is the area to be tested? What are the needs of the child and his family? And what about your perspective and your experience? So actually this is, in my opinion, main questions that usually consider as a limitation when you are going to examine or to assess any of the child with neuromotor impairment. Are you again going to focus on the muscle tone issues? Are you going to focus on the hand skills? Are you going to consider the needs of the family, because the mother concerned with the heel off, let's say, during walking? Or you will keep all of that aside and you will depend mainly on your experience, your perspective, your, let's say, issues that make you satisfied that you need to cover certain algorithm, certain frame of work, regardless the problems of the child or regardless the health conditions. That's why I think the main question for this talk is what is the philosophy of the assessment. I'm definitely happy to have this live presentation, but in 45 minutes I will not be able to deliver some of the specific manual skills or let's say, in my opinion, manual skills. This is a little bit difficult to conduct by a live online presentation in 45 minutes. But if I can deliver the philosophy of the assessment, I think that will be the main objective from our talk today. So I'm sure that all of the participants, all of the audience, they have a rationale, they have a protocol for the assessment profile. But let's try to organize, let's try to think in a sort, I know it's sort of philosophy, maybe a little bit not related that much to the scientific issues, but we need at the end to organize our mind in the way of thinking why we are going to conduct one and we are not going to conduct Z. So if I'm talking about the philosophy here, definitely I need the sort of frame of work. I need a platform that all of us can understand and can start from. And that definitely delivered from the WHO by the ICF model, the International Classification of Functioning, Disability and Health, which built already from 2001 at a framework for the code dimensions of all the health conditions experienced for any patients with any health conditions. And this ICF model, which created at 2001, already being adapted with another version, confirmed with the children and youth, which is our concern in this talk today. So, a little bit step away from the assessment profile, and we will back again, just try to figure out the concept of the ICF model. If I'm saying that the health and disease determinant consists of a functioning and disability domains, and definitely we have other contextual factors. So, the function and disability are described or considered as a dynamic interactions between the body functions, body structures, activities, and participation domains. In addition, we have a contextual factors which include environmental as well as the personal factors that definitely influence the disability and function. So in a brief way, if I'm going to deliver a simple question or a simple example, let's say now, I'm going to my work in the early morning, and going to my work, this is one of the life situations that each one of us is doing. Either you are students, so you are going to your school or your university, you are a physio, going to your hospitals and all of that. So this is your participation. You have a job, you have a mission that you are doing every day. So that consider my participation every day to go to my work. By what? By certain activities. So I'm leaving my house, walking, getting inside my car, and sit down, start to drive up to the building of my work. So I have some of the activities should fulfill to be able to participate in these issues. And to be able to engage in this kind of activities, I need a healthy body function and body structures for these activities. So if I'm saying that I need to walk, I need to sit down, I need to drive, that means that I need that musculoskeletal system to be intact, integrated with a proper muscle function, with a proper muscle tone, with a good flexibility and healthy bones. So that means if I have a problem in my body structures and my body function, I will never be able to being active in these activities, let's say, and I will not be able to engage in that. So by the end, I will not be able to go to my work as a life situation every day. So if we have a problem in these structures, in addition that, let's say all of these structures are being well, but you have some of the environmental issues. Let's say the street or the highway is freeze today with huge traffic issues. So this is an environmental factor which is out of your hand, but at the end, it interferes with your participation because you went to your house or your work or your school late. Maybe you are missing some of the essential meetings or something like that. So sometimes we have some of the contextual factors that may interfere, like the environmental, or some of the personal issues that maybe you are going to be busy with phone calls or something like that, make you a little bit late to participate and go and being on time for your work. So if we have this hierarchy and this model for the ICF, we can use it. And this is the diagram for the ICF. You can Google and you will find all the details about the ICF model by this way. So this is the diagram about what we mentioned, that we have two sections, functioning and disability, including the body function, structures, activities, and limit and participation. And on the other side, you have a contextual factors, which including the environmental as well as the personal factors. So let's say here, now we have a health conditions. Now we have a child back. Now we are going back to the issue of the assessment, try to make a link and try to find again the philosophy of the assessment procedure that we are going to conduct. So this is the structures of the ICF models in further details. And now if we have an example, a health condition like a cerebral palsy or spina bifida or brachial plexus or whatever of the health conditions that you are working with, the first point you need to ask yourself about, if I have a child with spina bifida, let's say, regarding the body function, definitely the neuromusculoskeletal and movement-related function will be disturbed. And now you need to go further in details. Are you talking about the disturbance in the bone function, in the joint function, in the muscle function, or globally affecting the movement function generally? So we can go step by step in all of these sections in the ICF model. And let's say we are going now to highlight on this point. I'm again sorry because the zooming is not suitable with the live presentation, but this point is belonging to the muscle function, which called muscle tone. And all of us understand that we are talking about spina bifida, which a majority of them are at the level of the lumbar or lumbosacral. So we are talking about a low tone or hypotonia of the lower extremities. So by default, in this health condition, I have a disturbed body function related to the muscle tone. So I have now a sort of disorder of the muscle tone, and that's what we call impairment. So now I have an impairment of the muscle tone, and this kind of impairment, which is related to the condition of the spina bifida, will definitely affecting many of the other consequences of the ICF model. So by nature now, what I'm going to do, I'm going now to examine the muscle tone. So this is the rationale, this is the way of thinking, that if I understand this kind of concept of the ICF model, now it will be pretty easy for me to select what kind of key area first that I need to examine, and by default, what are the tools that I can use. So if I'm talking about the muscle tone assessment, I can use a modified Tardieu scale, I can use a modified Ashworth scale. We have many of the scaling systems that we can use. On the other side, again, if we still the same scenario of the spina bifida patient, and now we are talking about the body structure. So, to your knowledge that you know that many of the children with spina bifida, sometimes they have a hip instability sometimes, which could be either subluxated or dislocated. So in this brief way of the details of the body structures, I can go to the specific region or specific joint, specific area to examine. And by this way, again, I have a philosophy why I am doing like that. Now let's jump about the activity and the participation. And for us as a physio, definitely we are more concerned with the mobility, which represent code D4 if you are going in details about the ICF model. So under the mobility, we have many of the sub-tracks of the activities and participation that every one of us is doing every day. And let's say here we have a changing body position. So if you are concerned now with this kind of activities, which is a changing position, now you will start to think about how can I examine, how can I assess the changing positions. You may think about using some of the subjective scaling system, easy one like screening of the Denver developmental screening test. It's a little bit subjective screening as we mentioned, but you can do it. Or you are going for further objective, reliable, valid assessment procedure for this kind of activities like the gross motor function measure, let's say. So why we are doing that, why we are selecting this kind of tools? Because we identify the key area. Again, because we are concerned here with this kind of activities. Another example, if we are talking about this child with spina bifida, that he has a sort of limitation or abnormality or difficulty to walk. So you may think about some of the assessment procedure to examine walking either for a short distance, that could be like a 6-minute walk test, 10-minute walk test, 2D, 3D gait analysis. It depends on what you are exactly looking for. But again, the main issue that you are identifying well, the key area that you are looking for. So, try to collect the data together. Now you are proceeding for the assessment. The first question that you have is the health condition, the disease, the participation restrictions, the activity limitations, and the impairments. If you highlight about these 4 items, I think you will have now a comprehensive assessment matching exactly the requirements, the needs of the child, the main problems that interfere with, and considering the International Classification of Functioning Disability and Health. So let's go step by step now. For the health condition, any sort of disease or syndrome, let's say like the cerebral palsy, I need to confirm about the health condition. Sometimes we have a referral letter or report that clarify in details about the diagnosis and even the classification or the type. So let's say, back to the case study that we mentioned before, the child is diagnosed as a cerebral palsy, left unilateral spastic, let's say, or left hemiparetic child, whatever the classification system that you are using. However, sometimes you need to spend much more time to confirm regarding the health conditions, because sometimes you have a patient without a referral letter or without confirmed diagnosis. So in this condition, you need to confirm about the medical health as well as some of the laboratory investigations. So this is one of the points that you need to consider when we are talking about health condition or the specific disease that we are talking about. I will just get a brief seconds because I need to get sure that the live presentation is working. If any one of the participants just can give me a tip or sign that the live presentation is working well. Yeah. Or my voice, I'm a little bit worried from these issues. Yeah, okay, so thank you for these tips. Great. So, back again, we try to summarize the assessment issues. So we were talking about the health condition, and as we mentioned before, sometimes we don't have a crystal clear diagnosis. So the medical history here is very important to confirm about if you are talking about cerebral palsy, so you have some of the risky factors that you need to figure out to confirm or to get about the laboratory investigations. The participation restrictions, and I think this is the cornerstone for any of the practitioners in our specialty, or even if we are talking about surgeon, pediatrician, neurosurgeon, whatever the diagnosis. Participation restriction is the main point that we need to set up our treatment plan depending on. So, participation restriction, as we mentioned, this is usually, let's say, the chief complaint, the significant, the market complaint for the parent as well as the child. And it must be a daily life situation. So, it's not sort of participation that you need to do it accidentally or in a chance, but you have to do that on a regular basis. You have to go to the bathroom every day. You have to get a shower. You have to feed yourself. You have to go to your work. All of this considered as a participation. And the main questions that you need to ask the parent or the child, if the child can express his need or her needs, that what is the participation restrictions, what is the daily life situation that you are struggling in front, that you have a limitation to proceed in. And for this key area, you either may depend on some of the objective scales like we mentioned before, like the gross motor function measure, 6-minute walk test, 2 or 3D gait analysis. This is again depending on what exactly the chief complaint or the participation restriction coming from the parent or from the child. Now what about the activity limitations? The activity limitation either gross or fine motor skills, like crawling over, sitting, grasping, releasing, touching, running, walking, and all of that. And what are the main assessment tools that we can use? Again, it depends on the kind or nature of activities. As we mentioned, we may use the gross motor function measure, B-Body developmental motor scale, Denver developmental screening test, Alberta infant motor scale. We have many of the assessment tools and equipment that we can use to figure out and assess these key areas. Now the impairments, and I think the impairment is the most crystal clear issues and point that all of the practitioners in any disciplines spending a lot of time to assess or to examine. And as we mentioned before, that means that we have a disorder of the body function or body structures, like what? Like weakness, spasticity, stiffness, low visual acuity, tightness, hip dislocation, spinal deviation, all of that considered as an impairment. How can we examine? What are the major famous assessment tools for that? If we are talking about weakness, so manual muscle test could be one of the assessment procedure. If you are looking for some of the objective measures and you have an isokinetic, you can proceed for that. Definite, that should be related to the age of the child and his cognitive level. Modified Tardieu scale, passive range of motion. All of these tools could be considered if you are looking to trigger the impairment in the body structure and functions. This is some of the examples about the assessment tools or procedures that we are using in conditions like the impairment. Modified Tardieu scale, in which we are going to measure the resistance coming during passive stretching or passive elongation of a specific desired muscles, because here you are looking to identify and differentiate between the muscle length as well as the spasticity or hypertonia. Let's say here we have many of the examples. Specific here we are talking about specific structures, hamstring or the posterior knee capsule, let's say, or the soleus or the gastrocnemius, or the short adductors, long adductors, or you are looking for certain joints like the knee varus valgus, iliopsoas if you are looking for the hip flexors. So all of these illustrated figures and examples about certain assessment procedure that you are doing or using by passive range of motion, by modified Tardieu scale, whatever. Why? Because you are looking to examine the impairment, because you are looking for certain structures that you are looking for: spasticity, hypertonia, hypotonia, tightness, flexibility, power, and so on. So, before going to the end or conclusion of this presentation, I think again, sorry for disturbance, I think, yeah. So, as a conclusion now, I'm sure that any of the practitioners working with the children with neuromotor impairment has his rationale, his guidelines, way of thinking, protocol, approaches, whatever that you are going to say. But today we try to set up a framework or philosophy not only based on the experience going to deliver from an expertise to the students and so on, but we have an international language. We have a framework that we can implement based on a scientific clues, based on an evidence-based. And by this way, we will not be in a debate why you are doing like that and why you are not interested to do like that. So now we are being a little bit of the issue of the individual experience. However, it's important, definitely, but we need to set up a framework based on an evidence-based. And this is one of the examples about the evidence-based in the procedure in your practice, either with the children with disability in a general, or if you are a physio. Another point I think could be clear now, why the title of the topic mentioned that we are not going to assess a child with cerebral palsy, let's say, or we are not saying the assessment of a child with disability, but we said that we are going now to talk about assessment of children with neuromotor impairment. So I'm very dedicated that I'm talking about specific impairment, which is related to the neuromotor, the nervous system. And based on that, we are expecting some of the activity limitations. Based on that, we are expecting that we will have some of the participation restrictions. In addition, don't forget the contextual factors, which are related to the environmental factors as well as the personal factors that should be considered when you are talking about the assessment profile. So by the end of the presentation, hopefully being able to figure out some of the cornerstones, some of the tracks that we need to identify. And in a conclusion again, if I am back to the case study that I mentioned here, I will say that from the perspective of the ICF model, I can say that the participation restriction which mentioned here from the mother, that she said she was concerned about his using of the left hand and heel off during walking. However, this considered as sometimes activities, but I will here in need to further asking the mother about what is the limitation of being walking in and outdoor with heel off. Is it hinder him from engagement in sports activity? That will be a participation restriction. Is it make some of the limitation for him to walk with a family outdoor, like let's say going to walk in a mall or on the beach or something like that? Or difficult to be engaged sometimes in some of the playground activities with the sibling in the nursery? That could be a participation restriction. If I'm talking about the activity limitation, it's very clear here that the child can walk already, so he has a performance or achievement of the walking, which is fine, but the main activity limitation is related to his hand, that he cannot pick the beads, that mean any small tiny objects has a difficulty to pick by the left hand, and he is struggling for the bimanual skills. So this is the clear activity limitation that the child cannot do. And finally, what about the impairments? The impairment definitely mentioned in the first paragraph here, that the child has a weakness as well as a hypertonia of the affected side. So the ICF now is very clear in these dimensions, and based on this history, based on this case study, I can select the proper assessment tools for the child. So for the participation restriction, I will be interested to go for the Peabody Developmental Motor Scale to examine his playing activities, his fine motor skills, and that will be in conjunction with the judgment about his activity for the fine motor. For the walking with heel off, I may think about footprint, I may think about foot scan during standing, during walking, to judge efficiently about the weight bearing on the forefoot in relation to the hind foot. If I'm also concerned with the heel off, I may also select the balancing assessment procedure to identify the center of mass, to identify the line of progression of the pressure during standing as well as during walking. On the other side, for the impairment, definitely here I am looking to modify cardio scale to judge about the problem in the calf muscles. The heel is off either due to spasticity or due to a sort of tightness, or maybe a contractures. So I need to identify between all of these components by what? By modified cardio scale and passive range of motion that I can use to judge about this point of impairment. So hopefully by the end of this presentation and this talk, I will be able to clarify the concept and the philosophy of the walking through different assessment protocol and the assessment procedure for the children with neuromotor impairment. I think this is the time now for your comment, your questions about this presentation. And finally, I will clarify the way of contact that you can keep asking and keep in contact. Definitely, you are most welcome to do like that. And I think now we have almost about maybe 10 to 15 minutes for your questions. Okay, definitely you are most welcome, and thanks for all of your comments. أشكركم أكيد جميعا. Okay, one of the questions from Randa, advices for the intern. Sorry, it's not engage a lot of Arabic because I know that many of the audience, they are not Arabic. So that's why I'm using an English language. If I'm saying advices for the internship students, this is the time for your clinical practice in all of the domains, all of the specialties. And by the end of the internship year, let's say, you can start to find which scope or service that you are more interested in. So try in the internship year to be like a GB and scan all of the subspecialty to find what you are looking for later on. Thank you, Marwa. For the physiotherapy, how can I know if the child has a paralysis in the lower extremities? Okay, paralysis in lower extremity, this is, okay, I will try to get some of the questions first, then answer. I have another question from Sky. I have a question during assessment, how we can differentiate between the tightness and contractures. Okay. Okay. We need a good book for the CB cases. Okay. Okay. So let's now try to answer about these questions. Initially, how can we identify if the child or assess if the child has a sort of paralysis in the lower extremities? Paralysis here mean that you are talking about lower motor neuron lesion that could be like in the cases of spina bifida, let's say. So definitely in this condition, you need initially to understand and catch clearly the health condition. What is the disease? If the diagnosis is not confirmed, so in this condition and you have a paralysis, focal paralysis, let's say, or only in the lower extremity, so you may think about the umbrella of lower motor neuron lesion. Spina bifida could be some of the problems for the coda equina, maybe. So in this condition, some of the lab investigations like nerve conduction velocity and electromyography may help. In addition, for other assessment tools for the key area. So based on what we mentioned, the key area here will be related mainly to the impairment, which is the muscle weakness and paralysis. So manual muscle test, some of the reflexes to examine. Based on that, you can differentiate. The other question related to how we can differentiate between the tightness and contractures. Tightness is spasm. Shortening, this is the similar word that usually used in a different countries, in a different text, about the shortening or limitation of the muscle length, which could be corrected passively. So during your examination and the passive elongation of this desired muscle, you can correct that manually, passively by yourself. But for contractures, you cannot do that. So usually you have a minus range. You cannot go for the neutral position. So this is how you can differentiate between the shortening or dynamic, let's say, dynamic tightness and fixed tightness or fixed contractures. For the textbook, for the CB cases, there are many. I think if you are Googling or let's say just drop me a message later on and I can forward for you many of the free text and books that you can download directly. How can we know if the patient have a tightness or spasticity? Okay. This is another question. Very good question also, like how we differentiate between the tightness and contractures. For differentiation between the spasticity and tightness, modified Tardieu scale is one of the best tools that you can use because it's related to the angle of catch with a different velocity during your passive elongation. So for the spasticity, usually we are doing the movement in a fast rhythm, fast speed, because we going to excite the stretch reflex. So if you have a resistance a bit early during fast stretching, this is a sign of spasticity. Plus spasticity, usually clasp knife, usually catch and release. However, in the difficult, severe cases, you will not like that. You will find resistance throughout the range. So try to further read about the modified Tardieu scale, and I think by application of that, this is very beneficial to differentiate between the spasticity and tightness. Another question from Noura, is a CB ataxia equal to cerebral hypotonia? Okay, this is another good question. This is dependent on the classification system that you are using. Previously, many of the classification systems, like of Popath and the others, saying that CB could has a type called the hypotonic. But if you are using the classification of the surveillance of CB in Europe, they don't have a type called hypotonic cerebral palsy. What is the link between the hypotonia and the ataxia? The only link is that the ataxic cerebral palsy children, majority of them, they start with the low tone, and this low tone usually of the axial part. So we can say that majority of the ataxic cerebral palsy children started with the low tone or hypotonia or floppiness of the axial part more than the extremities. But not all of the children with central hypotonia or generalized hypotonia should be an ataxic. Another question from Princess Mom. For how many repeating could the patient take a Botox injection if the patient feels it's usually and sometimes it's not? If the patient feels it's usually. It's useful. Okay. Actually, there is no upper limit for using the Botox from the literature review. Let's say, if I'm talking about evidence-based, in some of the literature review, they are injecting Botox even 7, 8, 9 times for the children every 6 months, every 9 months, and so on, especially if that's belong to the medical insurance and the parent not going to pay for that. My experience and the majority of the experience of the professional expertise, let's say, that the Botox will not working that much after the 4th or 5th times because the body started to develop a sort of antibodies for this kind of toxin. Botox is a toxin. Don't be frustrated, but it's like in other medications. Sometimes you have a little % of toxin, so it's safe. However, because of this kind of antibodies, the response of the muscles to the Botox after 4th or 5th time, usually it's not marked. So I will say that after 4 times, I will not be too interested to inject Botox again. Another question from Zuna. All the assessment tools is subjective. How we can cover this point with no experience? No, actually not all of the assessment tools are subjective, but I will say that if I'm teaching for my undergrad students, definitely I will teach for them the basic assessment tools, which usually, like what you are saying, subjective. But if I'm teaching for the postgrad, master and PhD, definitely I will go with them for the objective, reliable, valid measurement tools. And this is the same scenario if you are a clinician. So if I'm a clinician, and I have tools, facilities, definitely I will go for an objective measures which need some of the training, some of the experience. But in the pediatric physical therapy, we have many of the assessment tools, almost covering all of the key areas that I mentioned before in my presentation. Moni, what about the muscle test for the pedia with the cerebral palsy? You can apply manual muscle test if the child has a good cognitive function and usually we are doing that after age of 3 years, but sometimes you have a smart child who is 2.5 years and he can respond to your order, so he can make an isolated muscle test. If the child cannot, either because of the cognitive function is limited or impaired a little bit, or maybe the child, or you are talking about infants, sometimes the child is too young. So in this condition, you are looking for a functional muscle test by playing, by some of the activities to judge about the efficiency of the muscle power. Another question, Saja. Kindly give us your recommendation for the updated websites about pediatric. And another question, how can assess the muscle testing for the child less than 3 years? I think I answered this point by playing, by try to enhance the child to move around, to make some of the activities, and by this way, let's say if you are looking for the hip flexors, ask him to roll over, or introduce for him a toy to touch by the lower limb, or to try to change his position from supine to prone. By this way, you can examine or judge about the hip flexors. So we still have a question about the recommendation for the website, and another question, do you think passive range of motion exercises could be beneficial to the patient during rigidity? Quadriplegic, okay. Do you feel oxygen therapy had a good result with the asphyxia? Can I use a pain scale with a pediatric patient less than 3 years or CB? So, okay, let's answer. About, about the updated websites, again, drop me a text after we finish on the link that I'll send to you, and I will deliver that for you. The visual analog scale for the pain before 3 years, I think it's even difficult if the child has 4 or 5 or even sometimes 6 years old, because sometimes the children either overestimated or they cannot express well. So I agree with you that to judge about pain for the young children, this is one of the problems that we are facing, and we don't have, in my opinion, I don't have a clear answer about this question. It needs further reading sometimes. We may find a suitable scaling matching the kids at the young age. For the exercises, passive range for the rigidity, if you are looking to preserve the mobility and to avoid secondary complication, you can go for passive range of motion, but definitely that will not put any value for any enhancement of the motor capabilities of the child. But if you are looking to avoid any complications, you can do like that. Quadriplegic case with unstable breathing and heart rate. I will say that in this condition, the child is not calm, alert enough. So you need to make a sort of damping. You need to keep the child much more relaxed, especially if you are talking about quadriplegic or child with rigidity. Calming down vestibular system may help you in this condition to stimulate. Deep receptors may help you in this condition to relax, and then you are going to conduct your procedure. For the oxygen therapy or hyperbaric oxygen therapy, it's I will not say complementary, but let's say it's not a basic intervention procedure. It could be plus. So it has no hazards usually, and the positive significant results over the motoric aspect is a big query mark. Sometimes it has an effect on the speech, on the cognitive function, on some of the oral activities, some of the visual skills, but I didn't read many of the strong evidence literatures that we can get a marked results from the oxygen therapy over the motoric aspect. What are the appropriate exercises for the child 10 months has a hypotonic CB? What is the good plan for the treatment of the Duchenne? And what should be the focus on? What are the benefits of the tilting table in the spastic patients? If I'm saying the proper exercises for the child that has 10 months with a hypotonic, again, I will try to depend on what we talked about. So what is the participation restriction now? If the mother said that the child cannot play with, let's say because he cannot sit, so definitely I will focus on the core stability to build up tension for the axial part. If the child cannot follow visually the peoples around, so that means that I need to work further on the head steadiness, head extension from prone. So the treatment will not be only related to the age, but will be also related to the other component that we mentioned for the ICF model. The treatment outline for the Duchenne, it depends again about, we have sub-classification of the Duchenne, but definitely the secondary complications is the main concern. So try to keep looking for the mobility, avoid further coping mechanism or secondary complication that will make the situation further difficult. Maintain the range of motion, maintain the mobility, maintain the efficient condition of the muscle as much as you can. Don't exhaust your patient. Don't make high frequency of the treatment sessions on a weekly basis. Working in a low dose aerobic exercises is the most better for them. What are the benefits of the tilting table in the CB spastic child? That depends on his age, his capabilities. If you are talking about child with more impairment, difficulty, so the tilting table will add some of the weight bearing, bone mineral density, alignment of the hips, but to do like that should be not less than 2 or 3 hours, and sometimes the children cannot withdraw, and bear this kind of activities. So again, this question depends on the capabilities of the child, potential, age, and so on. How you are managing the child with behavioral problem during the session, if it's affect your goal. Okay, for us as a physio, it's sometimes definite with the children that actually, I have a note now that I have only 1.5 minutes. So, before time is finished, you can keep in contact me on this name, either on Twitter, Instagram, or Facebook, Dr. إيهاب والي EG. Or just Google with Ehab Wali, you will find my social media pages, and all my social media pages is for the scientific activities. It's not a personal. So even for the Snap, either Snapchat or Twitter, Face, Instagram, you can. This is my name, and you can text me at any time. I'm sorry that I will not be able to finish and answer all the questions. We can keep going later on. For Saja, for your questions about the behavioral, this is a very good question, and it needs a lot of debate a little bit, and other questions. Again, sorry, this is not my issues. This is the protocol for the live Instagram. Again, by the end, I'm very thankful for your participation. I'm thankful for the invitation from PTideas. Hopefully we will be able to meet again, inshallah, in other live presentation or other courses. either in Saudi Arabia or in Egypt or sometimes in many of the other countries. Next month, inshallah, I will be in Jordan, in Amman, conducting a workshop there. And thank you for your